Good evening, everyone. Hello, Facebook Live. This is Karen Hall from Cancer Support Team, and we have such an awesome guest speaker tonight. What do you know about colorectal cancer? Well, if you don't know anything, this is the right place. You need to be here tonight. Cancer Support Team mission is to empower, encourage, inspire individuals by cancer. And we do that many ways. And this broadcast tonight is just one of the ways. We do support group meetings for our survivors on the first Wednesday of the month. We have support group meetings for our caregivers, which is quarterly on the second Wednesday of the month. We provide free wigs, free care bags. We do one-on-one support. We also have a resource list because your life just don't stop when you're diagnosed with cancer. And we're here to walk the journey with you. So sit back, get your drink and enjoy our conversation tonight on colorectal cancer because March is colorectal awareness month. And so it is time for us to broaden our interest and understand and know what we potentially have to deal with. Okay, so we have our guest speaker is Dr. Rieser. She is, and let me tell you about her because she's a powerful lady here, even though this month is also Women's History Month, right? So it's really a double duty for me to have Dr. with me. So she completed her general surgery resident at the University of Pittsburgh and is currently completing her fellowship in complex general surgical oncology at the University of Chicago. Dr. Rieser clinical training focuses on cancer of the digestive tract, which includes the stomach, appendix, colon, and intestines, and management of locally advanced and metastatic cancers of the abdomen. So, without further ado, I'd like to introduce you with Dr. Caroline Rieser. 1 minute, let me spot.
Okay,
There
great,
you go.
fantastic. I'm going to go ahead and share my slides. Karen, thank you for such a wonderful introduction. It's really lovely to be here today, and it's so wonderful to be able to be here. I really support you guys' mission, and I think it's so important to, as you said, walk the walk with people while they're going through this really challenging journey, whether it's as patients or, you know, people who are living through the experience or having a loved one live with the experience. So thank you so much. So today, I'm going to talk to you all a little bit about colorectal cancer. I have some slides just as general information, jumping up points, but really I'm just here to help facilitate discussions and answer any questions that y'all might have. So if anything kind of comes up or you want to know more, just feel free to jump in and we can just chat, okay? So we were just going to talk briefly about, cancer statistics. We'll talk a little bit about, what is the colon? What does it do? How do we prevent colorectal cancer? How do we screen for it? What happens after you're diagnosed with a colorectal cancer? What comes next? What are the treatments that we currently have available? And for people who are, treated for colorectal cancer, what does surviving colorectal cancer look like? And what does the rest of your life, getting back to living really look like for you? So as a little bit of background, so colorectal cancer overall, the good news is it's decreasing. So over the last 20 years or so, we've seen rates of colorectal cancers decrease in the United States for both men and women. But a lot of that comes because we have really good screening tools at play. And so for people who have access to screening and who have access to these modalities, it can be a really powerful tool to detect cancer before it becomes cancer, which is really the ideal and the best way to have the best outcomes from treatments. But importantly, despite that, colorectal cancer is still the third most commonly diagnosed cancer among both men and women in the United States. and a little bit about, what does my colon do? What does my rectum do for us? I don't think most of us really think about it day to day, but, it does a very important job. So, stool comes in from, we take food in, it gets digested by our stomach, it gets absorbed by our small intestines, and then that liquid stool hits that first part of your colon, which is called the cecum. Your appendix, many people have heard about the appendix, hangs off the cecum. And then from there, the stool kind of goes through the ascending colon, the transverse colon, the descending colon to the sigmoid colon, and then eventually out the rectum and out your bottom. And so while it's doing that, your body is doing a lot of absorption of water, electrolytes, and different vitamins. And it's also your colon is doing a lot of important things, as a reservoir for stool. So allowing you to kind of maintain things so we're not always going to the bathroom constantly. So very important job, but it's important to note that people can live really normal lives after some or even all of the colon or rectum is removed. So even though, day to day it's doing a lot of work for us, it's one of those things that we can actually intervene on and resect or take out without any major issues. So in thinking about, prevention is always what we think about first in terms of, whenever we're treating a disease, we think about how can we prevent ourselves from developing colorectal cancer in the first place. And so the good news is that there are things that we can modify or have some kind of control over. In general, things like smoking and alcohol intake are associated with increased risks of colon cancer as well as additional other types of cancer. General things like high activity or, leading an active life, doing more than 30 minutes of exercise or, moderate intensity exercise a day are in general one of the positive side effects, in addition to helping your heart and your lungs, is it's been shown to decrease your overall cancer risk for multiple cancer types. And having a diet that's high in fiber and low in processed meats and things like that has also been associated with decreased risk of colon cancer. But the big thing is that the majority of these risk factors are things that you can't modify. And so the big one for most people is aging. As we get older, all of our cells are always growing and dividing. And as things happen, just the cells will, kind of continue to grow, things can go wrong. And the likelihood of that increases as we get older. Additionally, things like family history, is there colon cancer in your family? Is there rectal cancer or other types of cancer in your family? You can't change that, but it does definitely impact your overall risk. And we do know that there are certain kinds of colon cancer that really do run in families. And that'll impact a little bit about how we treat people going forward. And the other thing is that there are some medical conditions, things like inflammatory bowel disease, commonly known as things like Crohn's disease or ulcerative colitis, that can put people at increased risk of developing colon cancer down the line. And so when we recognize that people have these conditions, we tend to be a little bit more intense about recommending screening earlier and more frequently. So what is colon cancer? The good news is that we have a lot of knowledge over the past, several decades about sort of what happens. How do we go from a normal healthy colon to, a cancer that is at a certain stage? So most cancers we know start as a growth in the inner lining of the colon or rectum, which is commonly called a polyp, which you talked about earlier, Patricia. So most of the time, these polyps are small, and we're able to see them. And they start from these very small little growths that then get a little bit bigger and then a little bit bigger and a little bit bigger. And it's estimated that over about 10 years, those small growths can actually become invasive cancer, what we call invasive cancer. But before they reach that point, they're still in this like very limited stage where if we remove it, we take away all the cancer, we take away all the potential to develop cancer. And so we refer to them as being benign lesions or precancerous lesions. And this ties into the great news about colorectal cancer, which is that the best form of prevention we have is really screening. So there are lots of different screening modalities available. There are things like, I think the most common thing that gets talked about a lot is the colonoscopy. So that's where the GI doctors they'll have you come in for a procedure. They'll give you some medications to kind of be a light sedation. And then they'll take a look essentially at the entirety of the rectum and colon from the bottom up to investigate to see if there are any of these little polyps. And the great part about that is that they can both identify and then treat those polyps at the same time. So the GI doctors or gastroenterologists can actually go in and remove those precancerous lesions when they identify them. Or if they're too deep or too big to take out, they can actually go ahead and mark those to be identified and removed later to see what's going on. Yeah, go ahead, Patricia. Sorry.
How do they remove the polyps?
How do they?
How do they, yeah.
Yeah, great question. So it's really interesting. So they built these things called these scopes, which are essentially these long kind of camera flexible tubes. And they have
Okay.
these very fancy instruments where they are able to then go through. It's almost like a little snare that they pass through these very long tubes. It comes
Mhm.
out in the air. They're able to see it coming out, and then they're able to essentially loop those polyps and kind of capture
Ah,
them and then
ah,
take them out in their entirety. They send them off to other types of doctors called pathologists who their entire focus is sort of looking at these things under the microscope and saying, yes, this is 100% normal, or hey, there's a cell here, but you got it all. So, you're good to go. And then we look at the number of polyps that are removed on the colonoscopy or seen on the colonoscopy. We look at the pathology, and that kind of helps us think about next steps in terms of how to manage things.
mhm,
And there, in addition to colonoscopy, so the colonoscopy is kind of the whole shebang. It takes a look, ideally, it takes a look at the entirety of the colon and rectum from the very end to the very top and then back out again to kind of take a good look at everything. But there are other tests for people who aren't able or don't want to undergo the full colonoscopy. There are things like flexible sigmoidoscopies, which is a similar procedure, but it's typically evaluates the latter, the end of the colon as opposed to the entirety. And there are also tests called imaging tests that you can get with special kinds of contrast that you can drink, called CT colonographies, which is it's a non-invasive, so it's not a procedure, but you just have to come in and get images and take pictures. And additionally, there are completely non-invasive tests. So things like stool tests that we can take a look at and see, hey, is there any microscopic material that suggests that there might be cancer cells being shed in the lining of the colon? Or is there even at this nowadays, we can say, is there even any DNA? We're able to take those cells and really send them off to the laboratory and take a look and say, is there any hint that there might be something going on that might need more investigation into. And so the whole goal of this whole paradigm of taking a look in screening patients is that we want to, as we talked about, with Karen and Patricia earlier, was that you want to identify and really treat precancerous polyps. So you want to take out any polyps you might find when they're really at that early stage before they had the potential to get more aggressive and bigger and cause problems. Because if you take out all of any of those lesions when they're at that much earlier stage, you don't necessarily need any additional treatment. You just need to keep undergoing surveillance. So you don't need, surgery, you don't need chemo, you don't always need any other additional thing as long as we're catching things early enough, which is the goal.
mhm,
And then additionally, say some patients for some people, they might come and get their first screening colonoscopy and there might already be a more, aggressive or advanced polyp that they find.
mm.
The good news
Wow.
is that even when we find those, we can still treat them at, an earlier stage, catching things at an earlier stage. We know we always, patients tend to do better. We tend to have, need less treatment, less surgery and things like that to have better, better outcomes and better quality of life going forward. So if nothing else, I am big on promoting screening, when it's available and effective. And I think
Mhm,
colorectal screening and colonoscopies are definitely one of those things. And it's something that, is definitely covered for patients based upon age and things like that. But even for patients that don't have insurance, there are resources out there. The Colorectal Cancer Alliance and other groups do have resources to help people get secure funds to get the necessary screening. Because again, this is getting this taken care of early is a way to help people, keep them from getting sick, which is always the goal.
mhm,
So an important part of that is that, and something that you might have seen in the news over the past, few years, is that we know that the face of colorectal cancer is really changing. So in 2023, over 10% of new cases of colorectal cancer were occurring in patients that are younger than 50 years. So it used to be that the guidelines would say, you're 50, go ahead, like congratulations, over the hill, go get your colonoscopy, let's go. Now we're looking and seeing increasing numbers with younger patients. And so they've actually rolled that recommendation back at least 5 years, and it could be more depending upon an individual's history. But we now recommend that screenings start at age 45 And even earlier, if a patient has a family history of, significant colon cancer or even colon cancer in a younger individual. So all of that frequency, all of that, when to start, how often to do it, it's all very individualized based upon, your health and kind of what's going on and what's happened to those around, your loved ones and your family. So all of those things kind of play a role in things of thinking about what we need to do. I'll just pause a second. Does anybody have any questions or anything like that?
Yes, I do have a question.
Yeah.
What is the percentage of men versus women as far as occurrences?
Great question. Yes, I forgot to label it, but so it's slightly higher incidence in men. So men in this bar graph is meant to represent this half is women and this half is men, but it is roughly equal. And so it's not a big difference. It's almost a 50-50 split. So there's not, for some cancers, there's definitely, we know, a component of, say, like sex hormones or estrogen or progesterone, different things like that, or testosterone in men and things. But this is, fortunately not one of those types of cancer where we think that it makes a big difference in terms of sex and gender. Dr. Ong, I don't know if you'd like to add anything to.
Right, I totally agree. I think at this moment, the epidemiology is in constant flux, as Dr. Rieser mentioned. We're seeing a lot more patients with younger disease, but colorectal cancer seems to less be driven by some of those sex hormones that we associate with some other cancers. So roughly equivalent, slight male prevalence.
Thank you.
Okay.
Can I have a quick question?
Absolutely.
So when you were talking about you do the colonoscopy
Mhm.
and then you have the polyps. So this is kind of like two questions.
Yeah.
So the first question is, do they automatically remove all the polyps that they find when they go in? And the second question is, you said precancerous. So are all the polyps considered to be precancerous?
Great question. And so I think I'll answer your first question first. So there are some polyps that we can look at and say that has no potential. So of becoming something malignant. And so oftentimes if, there's little subtypes that the gastroenterologist will see that say like, oh, hey, that just looks like that there's like some inflammatory process or inflammation going on that doesn't look like anything's concerning. They usually won't remove all of them, but sometimes they'll just take one or two representative ones just to, confirm the diagnosis and go from there. The types of polyps that we tend to talk about come in two big buckets. So we think about, I guess I should say, like sessile, meaning like really it's called like a flat lesion. So it'll look a little bit different. It's usually a little bit whiter, it's firmer to the touch, and it'll look a little bit more concerning. And so those ones, anything that looks like that, they'll always biopsy or try and remove completely. And then they have these sort of like these polyps that almost look like mushrooms, kind of like this picture here, where it looks like growth. And then those they will tend to biopsy all of them and remove all of the ones that they see, because even though, when we think about it, to get to that point, to get to looking like that, it usually has had enough time that there's always the potential for a single cell, and it's much, the risk of getting those polyps removed is much less than the risk of leaving something behind and then saying, oh, you can wait 10 more years for your next colonoscopy, if that makes sense. So
Yeah.
In general, if they see anything that kind of looks like these much little like lower guys down here that really just like look like a small little, divot up on the colon wall, they'll still remove those, because it's just, the colon has this very like top layer of the colon can completely regenerate. It'll completely heal over in a few weeks. And so again, getting that sample and getting it out is much more beneficial than, trying to leave it behind. Did that answer your question?
Yes, thank you. Yes.
Absolutely.
So, as far as the size of the polyps,
Yeah.
say, for example, like it was very tiny. So
Yeah.
how long would, say, a growth happens, like maybe the fourth picture? You see the two little ones, the third, or even the third.
Exactly. So and we know that it takes probably in the realm of, everybody's different. So people who might have, say, we don't recognize or not known kind of mutations or other kind of genetic risk factors, it can be a little bit more aggressive. So there are some patients that are 20 years old, and because of the genetic condition that they have a ton of polyps, even though they're younger, but that's because they had these special genes that put them at risk to develop these problems. But for most people who are average risk, the anticipation of like going from the very far left to kind of the sort of fourth one or fifth one is around, 5 to 10 years. And that's why
Okay.
we kind of recommend that the frequency of the screening is kind of based around that, this idea that, okay, if we don't see anything on your colonoscopy, the likelihood that something is going to be growing in a problem within 10 years is low. The idea is that we'll still be able in 10 years to repeat the colonoscopy and see something and take care of it at that time. And we're not going to be missing, we're going to be not missing any larger, more aggressive tumors in the meantime.
Okay.
I have a question.
Yeah,
So
absolutely.
for a normal screening, it would be 10 years if they don't see anything.
Correct.
Now, what
correct.
happens if we're like right in the middle where it has
Yes.
precancerous polyps?
Yes, so all of that is very then specific. So if you have a precancerous polyp that's removed in its entirety, and so, you are not, you are no cancer, but they saw polyps and it was aggressive, or if it was the kind of type where they, think that you're at risk, they'll likely recommend that and this is all very dependent upon the gastroenterologist and kind of the medical team, but usually they'll want you to come back sooner. So sometimes they'll say, hey, you had a lot of polyps, but they all ended up being normal or benign. But we think that just because you had so many, the risk of missing something increases when you have more. So why don't you come back in 3 years or 5 years? And then if everything looks good, then we'll start to space it out back again. So it's very dynamic based upon kind of what we find, what the tissue looks like to those doctors who are looking under the microscope, and kind of, again, your individual risk factors.
Thank you.
Mhm.
Absolutely. So, what happens when we find a cancer? So what happens if, say, sometimes happens, we find like a mass that is too big to be removed. It's, gotten beyond that stage of just being a polyp or a little thing. It looks like a true, it's too big to be removed just by biopsying, or too big to be removed just by snaring. What do? But we take a biopsy, or the gastroenterologist will take a biopsy and they'll send it to the pathologist. And usually the pathologist will tell us that, hey, it looks like that there is something called, some type of colorectal cancer. It could be adenocarcinoma is the most frequent type, is the name of it. But there are lots of different types. So usually that is the start of what we'll call the staging workup. And so this is what happens, we sort of want to get a sense of, okay, we know that there's cancer. Let's figure out a little bit more about it, because that's really going to impact what everyone's plan is going to look like. And so we do a couple of things routinely with colon cancer. Most of the time we get a blood test. There are several, or a large number, of the colon cancers and colorectal cancers produce different tissue markers that we can then follow to sort of say how advanced or not advanced might this colon cancer be. It's called a CEA, is the level that we'll often check. Not all tumors make CEA, so it's one of those things that if it's negative, it doesn't help us. If it's positive, it gives us some sense, and then we know that we can kind of follow that going forward as part of our, checking and monitoring people throughout their treatment. The biggest thing that we will always get is we'll get a full chest a contrasted image of, your chest, your belly, to take a look at your liver and the insides to make sure that there's nothing else, or that see kind of where the disease might have spread, if it has spread anywhere else other than the colon. And so the big thing that we look at are typically, the big places where we think about cancer spreading to are lymph nodes, lungs, and liver, but it can also spread on the surface of the belly. And it can also, go different places as well, and different lymph nodes throughout the body. So getting the CT images, or the CAT scan images, helps us get a general sense of what's going on, how far the tumor, potentially we could even see the tumor on the CAT scan, but really helps us know, is this, a localized cancer, meaning it's just confined to the area, looks like it's just involving the colon, maybe some nearby lymph nodes? Does it look like it's more advanced? Maybe it's a bigger tumor that looks like it's maybe involving some of the nearby structures, like the tubes that drain the kidneys, sometimes in women, ovaries and things like that? Or does it look like there's more distant disease, like maybe disease in the lungs or disease in the liver? All of these things make a big difference in terms of how we then think about the best way to treat everyone. And the final piece is that, based upon some of the tests that the laboratory doctors will do when they take a look at the sample, we'll sometimes recommend that people see genetic counselors to think about testing for some of those mutations that might put patients at risk for colon cancers and other cancers. Because in addition to, we think about whole families risks, so if people have children and things like that, but it can also, change what we think about doing screening for other cancers like breast or pancreas or stomach cancers. And so it helps kind of put things in a larger perspective, and sometimes it changes the types of therapies that we can give. So getting that information can be really helpful, because modern colon cancer treatment is really, the great thing is it's really nuanced. We have a lot of things that we can do to help people, and so trying to make everything really personalized. And I think that that's kind of the second main point after, screening is super important. It's that every patient is different, every cancer is different. And so the sequence, there are some large buckets in terms of how we think about how we treat colon cancer, but sort of what we do, when, and what people need really depends on kind of you, the tumor, what's going on, how your overall health is, and what kind of treatment sequence might make the most sense for you. In general, the things that we tend to treat colorectal cancers with are things like chemotherapy, surgery, and radiation therapy, or some combination of all of those three. But really, every patient is different. So some patients nowadays with rectal cancer, they will get upfront, what we call like upfront, meaning the patients come in, they present with a rectal cancer. We start them with radiation and chemotherapy right away. And we know that that is really effective in treating and shrinking tumors, and sometimes even completely eliminating tumors, which is incredible. And so for some of those patients, we no longer recommend surgery. We treat the colon cancer, the rectal cancer, if it looks like it's disappeared with this combination of radiation and chemotherapy, we just watch. We watch patients very closely, but in those patients that have a good response to the chemotherapy, we found that we don't need to, put people through the stress of a major surgery. We can get by when we have really good effective treatments. We can get by with just those alone. But for some people with colon cancer, usually it's a combination of surgery first to get a better sense about what's going on with the colon cancer, and then depending upon what we see, in terms of the lymph nodes, the final, how everything looks once we get the whole tumor out. Some people are recommended for additional therapy like chemotherapy through the vein, or sometimes radiation, depending upon how things look. I just want to make sure I'm not missing any questions. Okay, perfect. And so I think the big thing to think about is that you should always feel really comfortable talking to your team, and you should feel, prepared to talk to your team, and they should be prepared to answer your questions in terms of, what is my treatment plan? What are the potential benefits? Like, what's the goal of my treatment plan? And what are the potential risks? What could go wrong? Because anytime we're doing anything, we always have the potential to have side effects or even complications. And, whenever we're intervening on the bowel, there's a lot of important structures down there. There's the bladder, there's the uterus, there's, a lot of things that are important for bowel function, urinary function, and sexual function. And so whenever we start making and doing interventions, there's a lot of potential side effects and symptoms that, it's good to be prepared for, because there could be potential changes in terms of, your quality of life and your independence. And I think everyone wants to make sure that you're getting a plan that works for you, and your life and your goals. And that really requires kind of having a good sense of what you want, and having the information to be armed to kind of make some of those decisions. So, but you should definitely feel comfortable asking those questions to your team, and in terms of thinking about it beforehand. I will say that as a surgeon, I am a little biased, so I will talk to you guys about surgery. But so I think it's importantly, the majority of patients with cancer, colon cancer that hasn't spread anywhere else, like the liver or the lungs, will end up undergoing surgery or be even considered for surgery. And there are a lot of different ways that we do surgery nowadays. you know, the picture up here kind of shows the traditional approach of open, what we call open surgery, meaning a bigger cut on the belly. But for most colon cancers nowadays, we're able to do a lot of the procedure or the majority or all of the procedure through what we call minimally invasive surgery or smaller cuts on the abdomen. So some of the things, if people have had other types of surgeries, they might have heard terms like laparoscopic or robotic assisted. These are all just different ways of us accomplishing the same procedure. But the benefits of that are, you know, you don't have larger incisions on your belly. Most people find that they're able to return to their, you know, daily activities faster, less pain, less time in the hospital. And so there are definite benefits to having those, you know, having those procedures done in a minimally invasive way, but it's just not always an option for every patient with every tumor. And so it ends up being very individualized. And what we take out is ultimately depends on, you know, our goal to, number one, get all the tumor out. And number two, get enough of those lymph nodes that, you know, drain the spot of colon to make sure that we're getting the right information to make the best decisions going forward. And so usually that means taking out, you know, part of the colon, or, you know, some of the common terms that you might hear is, you know, oh, we'll do a right hemicolectomy, or take out your right colon, take out your left colon. And then basically the extent of resection really depends on, you know, where the cancer might be, and then also on your individual risk factor. If we know that there's a mutation at play, you know, that might put somebody at increased risk for developing additional colon cancers down the line. Sometimes we discuss the benefits of, you know, doing a total colectomy, meaning taking all of the colon out to kind of decrease the risk for colon cancers in the future, versus, you know, the alternative is to not do that and then just do a really aggressive screening regimen, you know, frequent colonoscopies, sometimes colonoscopies every year. If people, you know, if the decision is made to try and do a minimal type of resection. And the important thing, and I think that comes up a lot when we discuss colorectal cancer, is that sometimes, you know, when we do take out all of the intestine or even significant part of the intestine, sometimes surgery means creating a temporary or permanent ostomy, which is when we bring that bowel up to the skin. And so instead of having, you know, stool go through your bottom, it's coming out through an ostomy on the abdominal wall. And I think that it's something that is definitely a change in terms of how, you know, how people do their daily functions. But for a lot of patients, it can be a lifesaver and a huge improvement in terms of quality of life. And so it's something that we always talk about whenever we talk about colorectal surgery. And it's always a possibility. But something that, you know, also we direct a lot of efforts into making sure that when we do have to create stomas, patients are leaving the hospital, you know, with the resources, the education, and the training for how to take care of everything and how to kind of adjust to this new normal moving forward.
Okay, can I jump in right there?
Yeah, absolutely.
Would you
Please do.
answer the question? I know they give you training. So what determines
Yeah.
if it's temporary or permanent?
Great question. So, and this is going to be a little bit technical, but so sometimes we think about when we put parts of the bowel back together, which is what we would do normally. Sometimes there are things that put people at increased risk of that connection not healing perfectly. So say patients that don't have, you know, good nutrition because they've had, you know, the cancer or the chemotherapy or what have you has kind of put them in a kind of a tough spot nutrition wise. If patients have to be on long-term steroids because of other medical problems, if people have had significant radiation as part of their treatment, sometimes we won't put the bowel back together right away, or we will put it back together right away, but we'll put in what we call diverting ileostomy, which is where we bring up some of the small bowel with the idea of just letting that new connection that we just want to really make sure heals really well, heal first, because it's much easier to treat something when there's not, you know, if there were to be, you know, a complication or an issue with that healing, it can make people very, very sick. So if you sort of get that stool out of there, you take the pressure off, you let things heal up nicely, and then usually in 2 to 3 months, people come back in and they get a surgery to fix the ileostomy, and then that's it. Sometimes does that answer your question?
No, yeah, that did.
Okay, good. Yeah. But
Mhm.
usually it's because we think that there might be an issue kind of putting that connection, or what we call like an anastomosis, at risk.
Okay.
And then
Thank you.
sometimes, you know, the area that we take out, so This kind of last picture shows what we call an abdominal perineal resection, or sometimes called an APR. But sometimes because of where the tumors are, we have to take out everything, you know, the rectum to the anus. And so that means that there is no more tissue, there's no more sphincter anymore to kind of hold things in. So even if we pulled bowel down, we'd be making everyone incontinent at that point. So there's no value added. So in that case, we have to make a colostomy, you know, or bring up the end of the colon to the skin in order to kind of preserve quality of life and help patients take care of things, you know, down the road. But a
Gotcha.
lot of these, you know, a lot of what we talk about before the surgery is kind of, you know, how likely we think it is, how, you know, what it might look like, and then kind of game plan from there. And so if we know that patients are going to need a stoma following surgery, either temporary or permanent, we'll have everybody meet with our stoma nurses, who are wonderful. So you can kind of see what the devices look like, see what the appliances look like, get some education beforehand, you know, potentially meet with people who have stomas, learn a bit about them, and then also potentially get marked so we know exactly where to put it. So it's going to be convenient for you going forward. So there's a lot of, you know, there's a lot of things up front and then after the surgery that we try and do to make it as seamless as possible for people. And then the big thing is that after surgery, so, you know, we estimate most patients for now for colon surgery are in the hospital anywhere from 3 to 7 days. That's really gone way down in terms of the length of time that people have to spend in the hospital. But after the surgery, we get a little bit more information about what's going on with the colon cancer, colorectal cancer. We make a plan with the ultimate like treatment plan. We can decide, you know, hey, do we need radiation? Do we need chemotherapy? Kind of what comes next. And then we make a plan for how we're going to follow patients going forward. Most of the time, with people, we're seeing them in clinic 1 to 2 times per year at a minimum. And then we recommend that people get a colonoscopy a year after surgery just to make sure that nothing was missed and everything looks good. And then we'll usually follow with blood tests and imaging every year going forward until we feel like we've really passed the point where people are at risk of developing additional cancer, and making sure that it's not going to come back. Because the goal is that if it does come back, we can find things when we can still intervene and still, you know, have a good outcome. So trying to detect cancer early and then recurrence early is really the goal of keeping it close tabs on people after surgery. But then even for people, you know, on top of the cancer surveillance, there are a lot of long-term effects of treatment that are, you know, important to know about and important to consider. You know, there are long-term, you know, whether or not you have a stoma, there are still going to be changes potentially in bowel and bladder habits that are going to be kind of your new normal. People can develop hernias after the surgery at the area of incision. After chemotherapy, people can have decreased sensation in hands and feet, kind of what we call peripheral neuropathy, and they can have issues with sexual health and intimacy. And, you know, from just a general standpoint of cancer, having a diagnosis of cancer and undergoing treatment, it's a traumatic, stressful event. And so there's a lot of post-operative, you know, post-treatment anxiety. There's a lot of anxiety that happens when people know that they're going to get their scans, you know, and sort of say, oh, geez, is it back? Like, what's going to happen? What am I going to do? And so there's a lot of effort now at kind of trying to deal with what we call more like the survivorship side of things, which is, you know, what is your life going to look like post-cancer? How do we improve it for you? How do we limit the impact that this disease that you are going to potentially be cured from, how do we impact or limit the impact that this might have on your life going forward? And how do we help you, you know, survive and really thrive after surgery and after colorectal treatment? So I did a lot of talking, so I'm happy to take any questions, but I just had a few resources that, you know, Karen, if you feel comfortable sending out, but there's a lot of resources out there for providers, for family members, you know, and just a lot of really good information out there and a lot of groups to get connected with. So if anybody's looking for more information, more things to learn, you know, happy to share. But I also just, again, thank you guys so much for the ability to come and chat with you guys, and I'd be happy to take any more questions.
Oh my goodness. Oh
Very
my goodness.
interesting. Very
We need to
interesting.
raise the roof, you know, instead of clapping, you know, I learned that we raised the roof because this was an awesome.
Interesting.
Oh my gosh.
Amazing.
You know,
Yeah.
I
Yeah.
told you about
Amazing.
15 and 20 minutes. but I did not realize how interested our participants is going to be. And
Look, and I'm
absolutely,
like, okay, keep going. I mean, I'm learning some stuff here. I'm
Me
like,
this
wow,
too.
you
is
made it so
good.
interesting,
Right.
Yeah,
Doctor.
very,
And
very
I'm sure,
interesting.
you know, it's one of those things that most of us are going to either have colon cancer or know somebody or work with somebody. So it's just one of those things that affects all of us. So in some way or shape or form.
Right. So I have one
Absolutely.
question.
Absolutely. Yeah.
You know, you talked about the lymph nodes.
Hmm.
Can you kind of explain to the people
Absolutely.
that don't know what they are and,
Sure.
you know, kind of where they're located?
Yeah, absolutely. So I think, you know, most of us know or have heard about, you know, we have these systems of fluid that kind of go through our body, right? We have arteries that bring blood to places, and then we have veins that kind of take blood back to the heart. But we also have what we call the lymphatic system, which kind of runs in parallel. And that is important for kind of taking additional fluids and absorbing additional nutrients and kind of taking additional things back to the heart. And so it's oftentimes that these little channels are kind of in all of our tissues, and they will often be, you know, the first place that some of those cancer cells will come to, you know, and be the sort of the almost like the guardians, you know, the first place, the first thing that place where cancer will stop before spreading elsewhere. And some cancers we know spread directly through blood, and so they'll go to different places, kind of wherever the blood goes. But for colon cancer, it tends to spread into the lymph nodes, and then directly from there, and then back into, you know, then through veins and things back into the liver and places like that. So when we are sampling those lymph nodes, we're basically going in to try and say, you know, we know that the lymph nodes themselves will kind of go in parallel with the arteries that are supplying the blood flow to the colon. And so when we take the colon out, we're taking the blood flow to the colon. And then part of why we're doing we're taking so much is because we need to take all of the blood flow in order to get all those lymph nodes to really get a good sample to say, you know, yes, there's tumor in these nodes, or no, there's no tumor, because that will make a big difference in terms of whether or not, you know, we know that we're trying to do, I would say, less harmful interventions that are not needed. So if you don't need chemotherapy, and we know that for patients that don't have lymph node involvements, that have, you know, very localized cancers that haven't gone so far through the colon wall, we know that we don't make people live longer or live better lives if we're giving them chemotherapy. And so the whole thing is about trying to target the right treatments to the right patients. And part of that is really trying to get that good sense of, you know, exactly where this cancer is and what is it doing, so that we can say, you know, with confidence that, you know, yes, you should get chemotherapy, or no, I think we can just observe you without any additional treatment. Karen, did that answer some
Yes,
of your question?
absolutely. Yes,
Oh,
yes.
great.
Are there any other questions before
Well,
I
just
ask another one?
real
Go
quick, I
ahead.
know you mentioned about a resource for people who may not have insurance to try
Yes.
to and I
Yes.
think that's so important, because I know
Yes.
me personally, I had lost my insurance for a
Yes.
while. And you're not gonna go to the doctor. You're not gonna get these
Oh,
things, because if you don't have insurance, I know
100%.
I went through it.
100%.
So, which is harmful in the long run, though. It's not like you do it intentionally, but
Absolutely.
you know,
Absolutely.
so whenever I hear someone say there are resources out there for people who would like to
Yes.
get screenings,
Yeah.
you mentioned it, and I was trying to
Uh-huh.
see, what did you say the name of it was?
Yeah, the Colorectal Cancer Alliance does have specific funds available, I believe, and like different financial resources that they can hook people up with in order to get access to screening specifically. And so
Okay.
that's the key thing, is just, again, with this idea that, you know, the more we don't want to be we want to be directing as much effort and money and time into preventing it as we will when people get cancer. Because, like, as you're saying, once someone is diagnosed with cancer, there are options and ways to kind of get people hooked into the system and get insurance, but we're already behind the 8 ball. So it's trying to, like your point, when insurance lapses, when things change, when people's
Yes.
jobs and situations change, we need to do a better job as a system of trying to figure out how do we keep those interruptions from disrupting, like you're saying, kind of care and making sure that people are still getting the care and kind of treatment that they need.
Good. Okay. Thank you. Exactly. Thank you.
Any other questions?
I don't know if this makes sense, but are all lymph node cancerous?
Not, no, yeah. So not usually. So usually, not every cancer spreads to the lymph nodes. And then even if you have a cancer, not all of those lymph nodes will become involved necessarily. So it's always just about trying to really sample and make sure that we're getting enough information to kind of make a good diagnosis. So it's just about trying to get the right lymph nodes to kind of see, like, is there a speck of cancer in there? And how does that kind of change what we need to do in terms of management?
Mm,
Thank you.
Yeah,
wow.
absolutely.
Very
So-
good.
Can you go back and reemphasize, most of the people here are breast cancer survivors.
Okay,
because
yeah.
that's kind of what we do.
Yeah,
And
Yeah.
so I know it's huge on prevention,
yep,
Right.
So,
exactly.
talk about, when do we start looking at this, kind of what are the
Yeah.
signs that make
Yeah.
us say, aha, maybe I need to go check this out.
Absolutely. And I would say, similar to that, so just like breast cancer, like you're saying, there's screening options, there are good non-tests that we can do, but part of the awareness is also just recognizing when there's a change. And so the changes can be subtle. It's, we talk about changes in bowel habits, like, oh, I'm feeling more constipated, or I'm
Mhm.
feeling like,
Mm-hmm.
some people, we talk about blood and stool, if they're noticing darker
Mhm.
stools or black stools or blood and stools, those can all be concerning features. But oftentimes the symptoms are very vague and it's hard, I think most of us have kind of abdominal, belly cramps or belly upset. And it's really when those things kind of keep on progressing, if people are feeling kind of more fatigued, if there's any concern, if there's any changes in sort of blood tests that people notice, sometimes people get anemic, and that's the first way that we find out, because those
Mm.
little polyps are
Wow.
just like dropping low bits of blood kind of over, weeks to months, and it makes people's blood counts drop. And that might be sometimes people come in because they're severely anemic, and that's our first sign that there's a colon cancer. But
Mm.
Wow.
I would say that sometimes it can present very dramatically, and people have the blood in the stools and things like that, but a lot of people just don't have any symptoms, and that's what can be so challenging. And
Oh,
so
that's kind of funny.
yeah,
Huh.
yeah,
And
because
so,
it'll just get bigger, your colon will stretch. And so if there's something
Uh-huh.
causing a blockage, oftentimes like it'll just compensate and kind of move around it until it causes a problem.
and
Wow.
so what age do we typically need to start
Absolutely.
getting our colorectal screening?
Yeah. And now it is the recommendation is
45?
45. Yep, 45 and
45.
earlier if your family has a history of colon cancer. So just like in breast cancer, where we say, we want
Yes.
you to get your first mammogram,
Right.
10 years before the youngest person in your family got breast cancer. It's similar
Mhm.
where if you have younger, particularly, if you have family that has had colon cancer in their 70s, 80s, it doesn't necessarily make a change. But if you've had family with colon cancer in their 30s and 40s, then that definitely ups the timeline. And so a lot of it is
Mhm.
kind of recognizing those risk factors and then kind of bringing yourself to the attention of providers and saying, hey, like, this is something I need, or this is kind of screening, and kind of having those conversations about, is it worth it to screen for me given all these features?
Yes. Okay. So I know, like with breast cancer, because when I was going through treatment, I lost my, as they call it, good government insurance.
Yep.
And so they have a program that's called IBCCP for,
Yes.
situations like that. Is
Yeah.
it a type of federal program or state program that has
State.
something like that for
Mhm.
colon cancer?
Exactly. So yeah, so once, and again, this is this whole idea of, it's kind of backwards because we'd rather be catching people before patient came to us with
Right.
colon cancer, but for patients that are diagnosed with colon cancer, it is an exception that we can then make an appeal to appeal for like Medicaid and things like that in order to get access to care. So that's one of those things that our social workers and people in our clinic will work on is, you come in with a new diagnosis of colon cancer, let's get you set up so that you can get the care you need.
Right.
Which,
Wow.
we would rather be delivering the care you need before the colon cancer, but we'll take what we can get currently and try and do our best.
That's
Yes.
true.
Wow.
Yeah.
Are there any other questions?
Wow. I learned a lot.
I learned a lot.
Oh
This
my
Me
this
too.
was
goodness.
Oh, wow. This was
very, very
awesome.
informative. Yeah, this is
Ooh.
extremely informative. So I want to thank you again.
Oh, Dr.
Oh my
Rieser, you are
God.
fantastic.
Yes,
Thank you. Thank you all.
Fantastic.
This
Yeah.
is,
yes,
you guys are doing,
different.
you guys are doing the work. So thank you for doing everything you're doing and helping each other and helping other patients and just, it's really hard. So thank you guys so much.
So the last resource
Oh,
screen,
sure.
can you send me
Yes,
that?
absolutely. Absolutely. And I'm
Yeah.
happy to send you all my slides just so that you have them
Oh,
Oh,
good.
that would be
Good.
that
in
would
the
be
future.
perfect because I'll
So
definitely post that, you
yeah,
know,
absolutely.
Right.
So yeah, lots of
kind
links
of
here,
send it
lots of
out with
places to learn more. So
yes, yes, yes. There's one that I'm not familiar with.
yeah.
It's this Cancer Hope Network. The
Yes.
other ones I kind of heard about.
Yeah. Yeah. So it's
Mhm.
the benefit of having this colon cancer similar to breast cancer where it's very common and a lot of
Yeah,
survivors is that there's a lot of
yeah.
resources, which is great, which is really good.
Is there do they typically have support groups for colon
Yeah,
cancer?
and I think so some of them will have, so I know the colorectal and the Cancer Hope too will both have peer support groups too. So, like
Okay,
peer programs and getting like paired with mentors and things like that. So that's, and also similarly programs for caregivers too, which is phenomenal.
okay.
Oh, great. Wow. Hmm.
Yeah.
Very
Well,
interesting.
it is after 7, and
Yeah.
I know I told you 15 to 20
Sorry, I
minutes
talked for a long
tops,
time. I
but
apologize.
No,
no, this
No,
was
it was
so
every
wonderful.
bit
so
was interesting. I
educational.
could hear you talk for another hour.
Oh,
I
well, thank
know it's like I'm thinking about other
Yeah.
questions that I can ask you to,
you.
No,
because you're
what you got to
extremely
do,
informative.
Karen, what you got to do is to bring her back.
I
Yeah,
do
Yeah.
I'm
have
happy
to
to come
bring
Part
back
her
and
two.
chat
back.
with you guys. I'm happy to talk about it.
Yes, we would
So
love to have her back.
I would definitely love to bring you back,
Right.
absolutely.
and talk some more because you are so
So,
knowledgeable about this. And
Well,
knowledge is power,
it is.
And
right.
so instead of sitting at home being afraid, saying,
Yeah.
I don't know, come join these support group meetings and hear the
Yeah.
right information instead
Right.
of getting on the internet and kind of
Yeah.
Googling, because sometimes you can
Mhm.
end up with the wrong information. So I want to
Absolutely.
That's right.
thank you once again for joining the cancer support team and
Absolutely.
sharing your knowledge and experience on colorectal cancer. And I look forward to connecting with you
Yeah.
again. Thank you
Very
so
soon.
much.
Yes.
Thank you
Thank
so
you.
much, doctor.
So much.
Thank you.
Yes,
You.
Nice to
All right.
meet you.
yes,
Thank
You
yes,
guys
you.
have a great
yes.
rest of your meeting and a great rest
You
of your
too.
evening, okay? Thank
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 you.
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 Thank you.
Bye.
Bye-bye.
Bye.
Bye-bye.
That was so good.
Oh my
Yes.
gosh,
Oh
it
my
was.
gosh.
Oh my
Oh my
goodness. That really
gosh.
was.
That
That
is
really was
something.
good. That really
Very
Hmm.
good.
was good. Let me get
Very, very.
here.
Francine, how you been, girl?
Wait
Good.
a minute. We're still on live.
Oh,
We're
are we?
still live on Facebook and we're still live on have our recording. So I just want to thank you all that's on Facebook. And once again, I want to ask, I see there are no questions on Facebook. Thank you so much. Dr. Rieser, she was absolutely awesome. She gave us some great information about colorectal cancer. She talked about screening, prevention, the procedure, the surgery. So if you want to know anything else about that and really want to get in contact with her, contact me because I got the hookup. This is Karen Hall from Cancer Support Team, and I want to thank you so much for joining us tonight. Join us next month for our next Cancer Survivor Support Group meeting, and we look forward to serving you. If you have a topic that you're interested in, drop me a line at info@cancersupportteam.net, and maybe I can work something out and get a guest speaker on to talk about it. Thank you so much and good night. Yeah. Okay. Facebook stop.